helped me actually develop some connections so that when I finished Spelman, I actually went on to work at the Centers for Disease Control in Atlanta for a couple of years before I went on to medical school. And I did that through a research program, once again, working in a toxin lab. So we looked at the exposure of toxins in certain bodily fluids in people. And it was really important, actually, right before I joined the lab, they'd actually done a big project centered around the World Trade Center um, exposures. And so they could see what toxins patients had been, or people had been exposed to, and then ultimately could relate that to development of cancer, because we knew that these particular ones were involved in cancer production. So I was there for 2 years, and then I went to University of Virginia in Charlottesville, where I did an MD and a PhD program. So it's a combined program. So for people who are interested in medicine, but definitely want to still have a connection with science, it's a great program. It's usually about 7 not to 9 years, just depending on how long your PhD takes you. And typically it's 2 years of your medical sciences. So that's all of your book work in the classroom setting for your first 2 years. Since I've graduated medical school, a lot of medical schools have started condensing those first 2 years. And so some programs will do more of like a year and a half, so about 18 months. But ultimately, it is all of your preclinical work. And then if you're in the MD PhD program, the summer between your first and your second year, typically you'll try to identify a mentor. So you will do a project usually for about 6 to 8 weeks, and then come back for the remainder of your second year. Once you finish your second year, typically there is an opportunity for you to do some of your clinical work with you either doing one of your clinical rotations, or in some programs, they may even let you do a few more of those before you go on to your PhD work. So for me, I think I did family medicine. This is so long ago, I can barely remember, but I think I did family medicine where my rotation was actually offsite. So it was not in Charlottesville. I worked with a community family medicine doctor for about, I think it was about a 6-week rotation. And then when I finished that, I went on to my third year of my program, which was my first year of graduate school. So the first year of graduate school, lots of basic science. I was in the neuroscience program at University of Virginia. So we did a lot of general neuroscience as well as some other classes. There are some electives that you can take. Because I was coming out of medical school, I did get some credit towards my PhD classroom work because we do, of course, a lot of physiology and pharmacology. So there was no need really for me to repeat a lot of those. So I did have the opportunity to do a lot more electives in that time. And then you're also trying to identify your mentor. So the mentor that I worked with between my first and my second year of medical school is actually who I ultimately ended up working with for my PhD. So my PhD was in the neurosciences, and I was actually studying Alzheimer's disease in a neurodegenerative lab. So our lab particularly looked at Alzheimer's disease, Parkinson's disease, and ALS. And we studied it from the mitochondrial standpoint, that there was mitochondrial damage in all of these diseases, which actually led to the pathology. So as it relates to Alzheimer's, we use something called a cybrid model. We called it a cybrid. It was basically a cytoplasmic hybrid where the cells were merged with mitochondria from patients with Alzheimer's or people or controls. And so these cells were all similar based on their nuclear DNA, but their mitochondrial DNA was actually different. And so that differed based upon if it was an Alzheimer's patient or if it was a control. And some interesting findings that we had there was that the Alzheimer's mitochondria, typically those cells would produce more amyloid beta protein, which is one of the toxic proteins in Alzheimer's disease. And so most of my work was actually looking at studying mitochondrial respiration and determining whether changes that we made to potentially treat Alzheimer's disease, whether or not those made any changes as it related to their mitochondrial respiration abilities. So we also saw that there were a lot of mitochondrial toxins that were demonstrated during that time. And one of the interesting findings was actually some unpublished data, but I found that when we actually treated these cells with some beta secretase or gamma secretase inhibitors, which are drugs to prevent the cleavage of amyloid beta into the toxic formation. That when we actually use those inhibitors, even though those cells produced less amyloid beta in the long run, it actually did not help them survive longer. So the cells were still impaired ultimately. Which I think was actually really important. And I say it was unpublished data because it was actually pretty controversial around that time. There were a number of secretase inhibitors that were out on the market. Or I shouldn't say out on the market, that was actually me misspeaking. They were not on the market, they were in clinical trials. But about a year or so after, I think that project did not get published, there was one of the clinical trials actually was stopped, and it was stopped because, oops, I just lost, sorry. It was stopped because actually they were not seeing any difference with patients that were on it. They actually felt like some patients who were on it were actually doing worse when it came to their Alzheimer's disease. They were progressing fast. So ultimately, my thought process there is that mitochondrial damage to these cells, which accumulates over time with the inability for patients to repair your mitochondrial DNA, it doesn't repair as readily as nuclear DNA when it's damaged. That starts a system where you have this cascade of other pathways that will ultimately lead to amyloid beta production and tau protein tangling, so that you develop Alzheimer's disease. That's just a kind of a little background. I mean, there's some more specifics, and that work that I did, I finished my PhD in 2011, so it's about 10 years old now. So there's a lot more data out there now. So then once I finished my PhD, I did a PhD for 5 years. So I finished in 2011, and then I went right back into medical school. So going back into medical school, it was the rotation part. So this is all the clinical work. And I probably did, I think it was about a year or so of almost about 9 months of the required rotation, just because I had that rotation that I did before my PhD. And then you get a little bit of your elective time covered by some of all the PhD work that you've done. But I knew pretty much going back into medical school that I wanted to do something in neurology. So neurology was kind of my first love, even from my preclinical years when we got to our neuroscience sections. I was always fascinated by how quickly we could try to localize where things were happening. All the different things about pathways and neurotransmitters was always extremely interesting to me. So pretty much knew I wanted to do that. But when it came to kind of a clinical part of neurology, I was a little bit more fascinated by the kind of Parkinson's disease stuff more clinically than Alzheimer's disease. So I think Alzheimer's disease, absolutely still love the disease from a scientific standpoint. There's a lot we need to learn about it. But ultimately, we don't have a lot of treatment options for patients. A lot of the therapies that we are using are probably the same therapies we've been using for probably more than the last 20 years. So like I said, going back into medical school, I did all of my rotations, tried to, shine on my neurology time, speaking a lot, of course, with my attendings, letting it very well known that I wanted to go into neurology, and then ultimately put in my application for neurology residency. So, and then I think some additional electives that I did some things in nephrology, so the renal section. I can't remember everything that I did then. So I'm going to skip over that because I don't remember all the electives I did, but tried to do some extra ones that I may not see so much once I finished out. So then I matched at Vanderbilt University in Nashville. So for anyone who doesn't know, the way that medical school typically works is as you're going into your 4th year, which would be your last year of medical school, you put in your application recommendation for the area that you want to go into. Once you put the application in, you'll start getting interviews. When you get these interviews, of course, you interview and then you put in what we call a rank system. So you rank the programs that you like, and then those programs also rank you amongst all of their other applicants. And then there's this algorithm or some weird thing that we all still don't completely understand, but it basically matches you based upon who matched you pretty highly and where you matched. And so hopefully it's a great match. That doesn't always happen for people, and there ultimately are times when people don't match, and there's a whole other system for that. But you match, and then you go on to where you're going to go. So in 2013 is when I started my my residency. So I finished medical school in May of 2013, and then started in July of 2013 in Nashville. So the first year of neurology residency is ultimately your internal medicine internship. So for Vanderbilt, I did both my internship and my residency at the same place, but that doesn't always have to happen. A lot of people will end up doing their internship somewhere else, and they can do their residency at the place they ultimately match with. So, but Vanderbilt's ultimately what we call like a categorical program. So it's one where you kind of do everything in the same place. And so internal medicine, you usually will do 4 weeks on neurology, 4 weeks in the neurological ICU, and then the rest of your time there is all internal medicine. So you're rotating through cardiology and gastroenterology, some of the outpatient clinics like endocrinology or rheumatology. You're spending a lot of times on the wards, admitting patients, so that you can basically just get accustomed to all of the medical issues that you would be ultimately managing if you were an internal medicine doctor. However, that's extremely important for neurologists to know all of the medicine part, because I mean, one, there are a lot of conditions in neurology that actually come about because of a neurologic disease, because of a systemic disease. There are many times that we're consulted for things like altered mental status, or whether or not a patient can proceed with a certain medication or certain surgery because of some neurologic condition they have. So it's really important for us to understand sort of the ins and outs of managing those things. So one example would be like for stroke. So of course, stroke is a neurologic condition. It's usually a blockage of an artery in the brain, or in some cases it could be a hemorrhage. So you could have a vessel burst and you have a hemorrhage in the brain. But it's really important for us to manage lots of things, including blood pressure. But blood pressure would be mainly something that we'd manage on the internal medicine side. But it's very important that we know exactly how to manage it, what are the best medications to use, and how quickly we'd want to lower their blood pressure in certain cases. We don't want to lower it too quickly right after a stroke, because there could be more damage done ultimately, because you're taking away any potential oxygenation that would be trying to compensate for the loss that they've had. So, so that's a really, really important year as you prepare for your neurology residency. So then the neurology residency itself is 3 years. So you start in what's your PGY 2 years, so your second year of residency, and then you do that over the next 3 years. The first year is mostly inpatient. So you're doing a lot of stroke workup, acute multiple sclerosis, flares, things like Guillain-Barré, dealing a lot with consults about altered mental status and any changes in neurologic function. So people who have difficulty walking acutely. We also get the more simple, like maybe outpatient things sometimes, where patients are coming to the emergency room for a really bad headache, or for maybe like a Bell's palsy. Those are typically things we see as outpatients, but patients come into the emergency room for a lot of different things. So it's a lot of inpatient work. It's really busy. There's a lot of call. You work very heavily with your senior residents as well as your attendings, because that's the time when you're really trying to build your knowledge base. And then typically you have a once a week outpatient clinic where you also will try to build your knowledge base for a lot more of the outpatient things. So managing people after a stroke, or managing things like peripheral neuropathy, once again, headaches, there's lots of migraines, back pain happens a lot, and then movement disorders come up a lot too. So that's pretty much the majority of their PGY 2 year. And then your PGY 3 year, you get to do a lot more electives or outpatient work that you aren't really doing as much in the second year. So most programs are very heavy in that second year that first year of neurology being inpatient, and the second year being more elective time. You will still do some inpatient work every once in a while. You'll probably do some calls depending on the program and how they structure it. But then you'll have more time to spend with like neuromuscular clinic, where they'll manage things like ALS or Lou Gehrig's disease. They'll manage Parkinson's or Huntington's disease. They will also manage brain tumors. We had a neuro-oncology elective. We have our headache clinics. There's sleep clinics that you can rotate through. So there's a lot of those electives that you can kind of learn all the ins and outs and work for some of those attendings. And then your fourth year of residency, which is ultimately your third year of neurology, is basically your senior year. And so that's the year where you're basically taking a more of a leadership role. So for all of those inpatient services that you served on in your first year of neurology, you're now the senior on that service. So you are helping your PGY2s to learn all of the neurology they need to learn. You're helping them to manage all of the conditions that, or all the things that come up during the day. So if they have an acute stroke patient, or they have an acute Guillain-Barré patient, you're, as questions come up, you know, if a patient crashes during the day, you know, you need to be ready to answer their questions. So you do typically do a lot more calls, especially in that first 6 months of your PGY 4 year. Because like I said, you are basically a senior. And then the last 6 months, you do get a little bit more time to probably do more outpatient work, because typically the PGY3s at that point are now kind of stepping into their leadership role. And so they'll do a lot more calls with the PGY2s around that time. So, you know, typically by the fourth year, everybody knows where they're going to go. They're either not doing a fellowship, or they are, or if they are doing a fellowship, they've pretty much matched. I think movement disorder is actually usually one of the last matches. It only matches in September of the PGY 4 year. A lot of other matches like stroke or neuromuscular will match in the PGY 3 year. So those people have to know, those residents usually have to know much earlier. So when I decided to go into movement disorders, which I'll talk a little bit about, you know, why I thought about that, I decided to stay at Vanderbilt. So Vanderbilt has an excellent movement disorders program. At the time that I was there, it was probably about 10 attendings, which is pretty good number for just a movement disorder division. They also do a lot of advanced therapies. So some of the things like deep brain stimulation, or infusional pumps for levodopa for Parkinson's disease are, you know, readily used at Vanderbilt. So those are not things that I would have to just kind of learn on my own or go to another institution to learn a lot about. I can learn about all those things with them. They also participate in a number of clinical trials. So there's of course a number of clinical trials for Parkinson's disease, and then some of the Parkinson plus syndromes, which I'll talk about in a little bit as well. And then they also have the designation as a center of excellence, both for Huntington's disease and Parkinson's disease, which are two strongly movement disorders. So most movement disorder specialists will take care of one or the other a lot, or even have a mix of those. So deciding on movement disorders, I think for me, and I'm sure every neurologist probably say this about their subspecialty, but I honestly think that movement disorders is one of the most fascinating areas. So even down to the basic science and talking about the basal ganglia and how you have what we call an indirect and a direct pathway, and that actually determines how you move, whether or not you move in a normal speed and with more normal tone, or if you're more on the slow side, like a Parkinson's patient where they can't really move very well, they may have some freezing when they're walking, or even if they once they start treatment, if they get more dyskinetic, you know, similar to how Michael J. Fox is, where he's moving all the time, learning about all the ways that pathway actually comes about and those patients develop either tremor or dyskinesias is extremely interesting. And then on the other side of it, more of your hyperkinetic or increased movement disorders, something like Huntington's disease, seeing those patients and knowing how that develops once again on the basic science or the basic anatomy side of it, I think is really interesting again. Then aside from just the movement disorders, there's lots of other pathology that a lot of these patients have. As it relates to Huntington's, a lot of those patients have psychiatric disease, and even ultimately will go on to develop some cognitive difficulty. And that disease typically affects sort of a midlife age range. So, you know, people in their 30s to 50s, you can have it earlier and you can, you know, develop it later, but typically it's at 30s to 50s. So there's also a lot of conversations around genetics and talking with families who may be affected when they find out that someone actually has been diagnosed. And then with Parkinson's disease, a lot of those patients also have some psychiatric disease. Typically, it's a lot of anxiety or depression, which can actually present very early on, even before they ever have any motor deficits. And they, you know, you're also having a lot of conversations about what does this mean. It's not typically an inherited disorder, but there will be, of course, a lot of questions about what should families expect for somebody else in the family, as well as what should even that patient expect. You know, is this a patient who's going to be diagnosed and within a year or so we're going to be in a wheelchair and have to start talking about end of life decisions? And I'm going to talk a little bit about Parkinson's and Huntington's a little bit more later, but typically they don't usually have to worry about that as soon as their diagnosis. I just, like I said, I was really, really fascinated by the basic anatomy, the pathologies there, and all of the other things that can happen in those patient groups. So ultimately, movement disorders is where I wanted to go into. So my movement fellowship was a year. Fellowships can be 1 to 2 years for movement. Typically, if there is a second year, there's probably a lot more research on the research side, but your first year is a lot of clinics. So you're rotating either through clinics with your attendings, or you'll have your own clinic as well that patients will come through. There will usually be a deep brain stimulation clinic if your attendings participate in that. So deep brain stimulation is one of the advanced therapies, and I'll talk about that when I talk about Parkinson's a little bit later. And then you get to see the whole gamut of essential tremor and all the other types of tremors, including Parkinson's tremors, all the Parkinson plus syndromes. So these are diseases that look like Parkinson's, but typically have some other things that are more prominent pathologies in them. And then you'll see, you know, Huntington's disease, dystonia. We do a lot of training for Botox or botulinum toxin for things like spasticity after a stroke or for cervical dystonia. Things like writer's dystonia, that sort of thing. So it's really important that you do a lot of training in that time. So I did a 1-year fellowship, and then at the end of my fellowship, decided to, I thought I was actually going to be in academia initially. I think most movement disorder specialists end up staying in academia just because of all the research opportunities. But an opportunity came up for me to build and direct a movement disorder center, actually not far from you all, but right there in Lynchburg for Centra. And so as their movement disorder specialist, I of course have my regular clinic, but I'm building what is a deep brain stimulation program. So deep brain stimulation, I'll talk about this here, is a technology that we use for essential tremor, Parkinson's disease, and dystonia. It can be used for some other conditions. It has been used for Tourette's, and in the psychiatric world, it has been used for depression and obsessive compulsive disorder, but I don't take care of those. Those are more psychiatric diseases. And then it has also been recently approved in the last 2 years for epilepsy. I also do not take part in that. That's usually run by an epilepsy specialist. So, so then the, hold on one second. Hold on one second.
She'll be back in.
I think the unmute and the end are sometimes very close together.
Yeah,
Service.
it's true.
Yeah.
Here she is.
Yeah.
Where's her thing located?
Okay. Okay, can you all hear me?
Yeah.
Okay, I apologize.
Your camera's turned though. Your camera's turned to the side here. And there we go.
Okay, that's better.
Yeah.
Okay, I apologize for that. Okay.
All right.
Okay, so where did I leave off? So I was talking about DBS. So yeah, so starting a deep brain stimulation program, but this technology uses neurostimulation in electrodes that are placed into the brain to basically disrupt what other pathology is there. So as it pertains to Parkinson's and essential tremor and dystonia, we don't have a complete understanding of exactly all of the ins and outs of how DBS works, but it does work. So typically, when you've identified a patient that would be a good fit for this therapy, they will go through a series of tests. There's usually what we call an on and an off evaluation for the Parkinson's patients. So a day when they come in completely off all their meds, and you see how bad their tremor is or their dyskinesias and all of those things. And then you have another day where they come in completely on, and you basically do their scoring for that as well, and basically determine if this is a next step for them. For the essential tremor patients, they don't typically do an on and off. Most of the essential tremor patients, if they are at that point, most of the medications don't work very well for them anyway. And then dystonia patients are also graded on a scale. So they will then go through neuropsychological testing, where we look for problems with impulsive behaviors or any severe depression or even some cognitive impairment that may not be initially evident in a clinical setting, like in the office. And then if they do pass that, we usually allow for a little bit of what we call dysexecutive function, but most of the time, I mean, you don't want there to be any cognitive issues severely, like they can't be demented, where we do get concerned if there is a lot of impulsivity already. The technology itself does not cause those things, but in patients who already have those problems, they don't tend to have as good of a response to the therapy. So that's why we choose to eliminate those patients out of the group. And then as long as they don't have that as a problem, they'll move forward with neurosurgery, just making sure that they don't have any other systemic reasons why they couldn't go through a surgery. And then they have what's either done as either 2-part or a 3-part surgery. Usually, so with us, it would be a 2-part surgery. At some other places, like where I trained at Vanderbilt, we did it in 3 parts. And that was just that the placement of the frame on their head is a separate surgical process than the actual placement of the electrodes. But there are different types of frames. And so some frames allow you to do both the framing and the insertion of the electrodes on the same day. And so with that, they will get the frame, they'll have electrodes that are put in, they can do one side or both sides. Depending on their age, we may choose to sometimes do an electrode just on one side first, and then do their second electrode on the other side at another date. Usually about a week isn't enough to give, but there are some centers who will wait 3 to 6 months before they'll put in the second one. And that's just because of things like tiring out. The exam, their surgery is actually done with them awake, because we do need to see parts of their exam. And so if a person tires out, all movement disorders typically go away when someone's asleep, so then we don't have an exam anymore. So they'll get the electrodes in, and then they will go out of surgery. They usually stay overnight. We just do a head CT, make sure everything is okay, watch them, and they go home, and they'll come back a week later for the for what's kind of like the battery pack or the IPG. It's put in their chest area, kind of looks like a pacemaker, but they'll run the wires from the electrodes down kind of behind the ear, down the neck, and into the IPG. They only need one IPG, so they can connect both sides to that one. And then whenever we communicate with it, we are communicating with the sort of the battery pack. So we don't have to do anything up here. As long as there's no complications, you don't ever have to really go back in the head for anything. Every few years, the battery pack will need to be replaced. Or if they have a rechargeable one, that usually will last them about 10 years or so. And they're actually starting to see that they can actually last even longer. But typically you only have to do anything with the battery pack. And then we basically manage it from there. So it's just programming them. So that is a program that I'm starting in Lynchburg. And so there's a lot of fine details. So I'm the neurologist who identifies the patient, determines the best target, because there are multiple target areas that we can go for. And then I work with a neurosurgeon to really make sure that that target is appropriate. So I don't do the surgery myself, but I would be in the operating room with them as we're listening to that target area. We can actually hear changes in the neurons that let us know we're in the right area. And then I'm examining them. So if they have tremor, I may have them like put their hands out, and I can probably see like how much the tremor is going, and we can actually stimulate at that time to see if the stimulation actually helps the tremor. And so I grade it basically on like a quartile scale to say like, okay, well, it's not helping, or maybe it helps about, 25%, or it helps, 75% or more. And then we're also looking for side effects. So this is an important thing to note, because some centers actually do this surgery asleep. And that actually can be done. It can just be, looking at the anatomy and making sure you're in the right place. And I think that's important, but, anatomy should be the same in all of us, but can differ a little bit. And so I think being awake is actually very helpful, because you can see that if you stimulate it, even if the tremor is helped 90%, if a person is having twitching or pulling of their face or anything like that, any abnormal sensations on that side, you may have to actually not use that target, because yeah, if their hand is steady, that's one thing, but now if they're doing this the whole time, they're probably not going to be very comfortable, and they're not going to like it, and you'll never be able to get them to a point where their hand is steady. So that actually does help us in the operating room. Sometimes we may have to shift the placement of the electrode just a little bit, just to stay away from areas where there are side effects. Or we may see that, hey, that side effect only occurs at a really high voltage rate, but we're already getting efficacy at a really low voltage rate. So we'll know, okay, well, if it only happens at 4 volts, but we're getting great efficacy at 1 volt, we may not ever have to go to 4. And so that's actually really important for us to know. So that's kind of like my role there. And then, once it's put in, I manage all of the programming. The neurosurgeon, like I said, they place it, they would do the follow-up checks just to make sure everything's healing okay. And then if that patient ever needs a battery replacement, they would replace the battery. But the other people that are important for a DBS program are the neuropsychologists. So the neuropsychologist would be doing all of the cognitive testing. Typically will also involve physical and occupational therapy. They will help with some of the scales. Neurology, myself, like I can do the scales. I usually direct them to which scales we're going to use as part of our approval process for the patients to go through. But therapies, occupational and physical therapy will actually help with conducting those things. And then there's always like a nurse coordinator and some other staff that can help with managing the scheduling part. So when you determine which patient, they'll put their neuropsych stuff on the schedule, put their PT and OT evaluation on the schedule, and then they'll make sure they're ready for surgery and all those things are lined up. What you don't want to have happen is, have them come in, get the first part of the leads put in, and then their battery got scheduled months out. You don't need that to happen. It's usually only a week difference between getting that placed, and they can't be stimulated if it's not in. So it's really important to have a coordinator in place that understands all those ins and outs, so that little things don't get missed. So that's kind of the main role that I play here in Lynchburg. And then, I see my patients day to day. So I see patients 5 days a week, typically between 9 and 4:30. And I'm almost 100% movement disorders. Every once in a while, I will see patients who don't have what would be classically called a movement disorder. And that's either because the chief complaint they may have doesn't tell you exactly what it is, right? So if someone's having trouble walking, it could be from Parkinson's, but it could be from something else. So there are many times when I've diagnosed people with other non-movement disorder conditions just because of what their chief complaint is. Or every once in a while, I'll just take on some patients because we do sometimes get like a long wait time if people are waiting to be seen. So that's kind of the day, that's my daily thing that I work on. So on a normal day, Monday through Friday, I go into clinic and I see those patients. So I'm going to kind of go over like a couple kind of general patients that I would typically see. So essential tremor. So essential tremor is the most common movement disorder that's considered a primary neurologic disease. It can affect anyone from teenagers up to your oldest patient in the community. But typically there are some peaks where patients will have a peak or the number of people in that group will peak around in the 20s. And then there's another peak around the 60s. Usually that peak is a little higher than the one in the 20s, but you do have young patients who have essential tremor as well. So that's also important to know because, not everybody shaking is Parkinson's. A lot of people see someone shaking, they automatically think Parkinson's, but the vast majority of those patients will probably end up having essential tremor. So essential tremor is what we call an action tremor. It typically affects things that you're trying to do. So when you're writing or you're eating, these are the people who may have some shaking as they move food to their mouth, or when they're writing, their hands get really, really shaky. Sometimes you may even see women who have like a head shake. I say women just because it tends to affect women more than men, but men can have the head tremor as well. And this tremor can affect the head, the voice. They can get a really shaky voice. The hands are the number one place where it affects, and it can affect the legs, though it doesn't always affect the legs as much. And then It can progress. So if you had someone in their 20s, you could expect that by their 50s or 60s, they may actually have much worse tremor. And those are usually the patients that we're also thinking about for something like essential, like DBS, as I talked about before. And then there are some medications that we use for them. So the medications either fall into the group of beta blockers, which are hypertension medications, or they fall into the category of anti-seizure meds. And they have their different side effect profiles. So, some patients may not be able to use certain medications because they have other medical conditions, or some of them work better than others. So typically the first two that we choose from that work the best are propranolol, which is a beta blocker. So because it is a beta blocker, works on blood pressure, keeping blood pressure down. We do have to watch for people getting lightheaded when they stand up, their blood pressure dropping too low, or their heart rate dropping too low. So those would be the main things that would potentially make us stop the medication if someone had side effects, or potentially if someone was on a lot of blood pressure medications already for hypertension, may not want to use propranolol just because they could end up getting more dizzy. The other thing to remember is that there are other beta blockers. And so a lot of times cardiologists or primary care doctors may have them on a beta blocker for their for heart rate or for hypertension. And so, I don't want to put them on propranolol in addition to one of those, but sometimes we can have a conversation about if we could switch out one of their others for propranolol, or if we could even increase the one that they have. So propranolol is the best beta blocker for it, just because it does cross the blood-brain barrier and it does have better efficacy, but sometimes we can use some of the other beta blockers, though they're not as good. The same should be said, though, is that propranolol may also not be the best option for their cardiac or their vascular issues. It is a good medication, and it can help lower blood pressure and lower heart rate, but doesn't really do it as effectively as some of the other beta blockers in the group. So a cardiologist might say, you know what, propranolol is just not going to get us to where we need to be from a cardiovascular standpoint, so they may not want to use that. And so then the next option would be primidone. Primidone is an old anti-seizure medication. It is still used every once in a while, but not used that often for seizures. There's a lot of other medications that might be better and don't have as many side effects. Primidone's biggest issue is that it causes people to be sleepy. It is metabolized into phenobarbital, so it's phenobarbital that's making people so sleepy. So the hardest thing there is that I typically have to start at really low doses in the beginning and just gradually move them up. And then another issue that can come up is in the older patients, if they start, having their other medical conditions, if they have anything like atrial fibrillation, or if they had a number of blood clots, we may have to consider not using it because it can mess with the efficacy of things like warfarin or Eliquis, some of the blood thinners. So, and then we have a few others. So there's gabapentin, topiramate, and sildenafil, and they all, once again, have their own potential side effects that can be used. That we have to worry about. But I see a lot of those patients, they will always, sometimes will come up with questions about balance problems. Essential tremor patients can develop a balance problem. So I will have to determine if their balance problem is related to Parkinson's or another condition, or if it really is the ataxia that we see in essential tremor. And then, so that's probably the number one type of patient that I see. And then the number two type of patient that I see is the Parkinson's patient. So Parkinson's disease is a disease with so they get stiffer and slower. They also develop a hyperkinetic movement, which is the tremor. And that is because of a loss of dopamine. So the neurons in their basal ganglia that normally produce dopamine have died over time. And when they died, they no longer have enough dopamine in their brain. So how we treat it is we give them back some of that dopamine. So we have a number of medications that are either dopamine replacements or they are dopamine agonists. So these are just medications that work on the receptors that basically activate the receptors and for the dopaminergic pathway to continue. But that is a disease that actually will last a long time. So typically from the time the patient has their initial symptoms, they've probably had this occurrence of disease pathology occurring for many years before that. but they can live with the disease for 15, 20, 30 years. So this is not usually a disease that we would expect a very significant decline over the first year or two. So that's a really important thing to know. And if there is a really significant decline, we may want to consider that maybe Parkinson's disease is not the main diagnosis or may not even be the diagnosis at all. So there are some mimickers of Parkinson's disease. There are the Parkinson plus syndromes. So those are things like multisystem atrophy, where they usually have a lot of blood pressure issues and their blood pressure drops dramatically when they stand up and they may pass out. There is progressive supranuclear palsy, where these patients tend to fall a lot. They have a lot more balance problems very early on, whereas Parkinson's disease patients, the balance problem typically happens many more years into the disease. And those patients with progressive supranuclear palsy also have some eye movement abnormalities where when you're having them follow your finger, if you have them go up and down, they can't purposely look down as well. And as the disease progresses, they actually will lose the ability to even purposely move their eyes in any direction. And usually the looking down part is what can also contribute to falls, because if they're walking down steps, they can't even use like their peripheral vision below them to see themselves, see steps. And then there are other ones like Lewy body dementia, which these patients typically have very similar symptoms to a Parkinson's patient, but they'll have hallucinations that occur very early on and cognitive decline that happens really early on. And there's a couple others like cortical basal degeneration, which has a lot more dementia early on and typically has more one-sided symptoms. They'll have a lot more trouble doing things for one side, not only because they're stiff, but because they end up being a little bit apraxic. They just may not know how to use that arm very well. And there's even a condition that we know as alien limb syndrome, where people will have things just happen. They'll be like writing and stuff, and you ask them, hey, what are you doing with your hand? And they say, oh, that hand belongs to somebody else. It's not mine. It's actually pretty fascinating to ever see. And cortical basal degeneration is not the only condition that can cause that. I've seen strokes cause alien limb syndrome too. But it's really fascinating to kind of see somebody do things and not know, yeah, why is somebody grabbing my head? And they'll actually ask you that, and it's actually their hand doing it. And then there's frontal temporal dementia, which is technically like a more of an Alzheimer's kind of dementia. Like they have a lot of trouble with speech and with memory, but then they can also develop a lot more Parkinson-like symptoms as the disease progresses. So with the kind of more typical Parkinson's patient, though, they usually respond to levodopa, or one of the dopaminergic medications. Hallucinations can occur, but are much later. Balance problems can also occur, but also a little bit later in the disease. And they can also have some cognitive decline. If you've ruled out that it's any one of those Parkinson plus syndromes, but they also don't seem to be responding to their Parkinson's meds the way that you would expect them to, you may also want to consider one of the true mimickers of Parkinson's disease, which are diseases that are not at all related to any loss of dopamine, but they just kind of end up looking like it. So vascular Parkinsonism is a very good one. A lot of patients have cerebral vascular disease. They've had a number of strokes. They have really bad hypertension or diabetes and high cholesterol, and they'll end up with a lot of changes on their brain that look like they've had a number of strokes over many, many years. And those patients tend to have a lot more lower extremity Parkinsonism. So they're really stiff and slow when they get up. They have a lot more freezing, and they don't really respond to the medications as well, because it's not the same pathology there. It's not because they just lost dopamine. It's also because even the receptors that would take up that dopamine are also lost, right? Because they've had a more thorough blockage of all of the networks in that area of the basal ganglia. Another good one is normal pressure hydrocephalus, which is one where they develop too much fluid in the brain. So they get sort of a typical hydrocephalus, except that it's normal pressure. So not one that you would see like you would see in kids, where they have sort of the increased pressure in the head and they get a lot of headaches. But this is one that over time, they get more and more pressure there, and they develop a little bit of a dementia. So we have some terms that we use to help remember it. So they're wet, wobbly, and wacky. So the wet part is they end up with urinary incontinence very easily. They just can't control urinary incontinence. They are wobbly because they fall a lot. They can't really walk. They even have what we call like a magnetic gait. It looks a little different from Parkinson's, but it can very much look very similar. So these patients almost look like they can't quite get moving, right? They look like their feet are stuck to the floor and they just can't really pick it up. And another important thing about it is if you put like black or white steps in front of them, or like feet, like paper feet, they can actually still walk because they can imitate it. It's more of what we call a gait apraxia. They don't really know how to walk as well when they're trying to walk normally. And then the wacky part is sort of the dementia side. So they, and that tends to be one of the later parts of it. And there's a completely different therapy for that. So they usually will get a shunt to shunt off that extra fluid. And then the last one I wanted to kind of cover really quickly are just some of the like dystonia spasticity things. So dystonia is any sort of like abnormal movement of a part of your body. So there's hand dystonias that can happen. A very common one is neck dystonia. So you may see people who have like a head turned or like turned on the side a little bit. And we have some medications that work for that. But one really important thing that we do use is Botox. So Botox is a brand. So I'm going to say botulinum toxin really, because there are some other brands. And so this is a botulinum toxin can inhibit the release of acetylcholine to allow for normal muscle movement. And so for abnormal muscle movement in this particular case, so if someone has a dystonia from that excessive movement, you can actually apply Botox to some of those muscles that are causing that movement and help to relax it. Botox only works for about 3 months, so they do have to get it every few months. And then we also use that for spasticity as well.
Did we lose her again?
So,
Oh, here she comes.
Okay, I'm sorry, I think I
We
hung
have
up on you.
We have no, it's okay. We have 10 minutes till we have to go to another class.
Okay, no problem. So, and I'm almost done. So apply the Botox to get it every 3 months. I think I just finished saying that, and I forgot what else I was saying. So spasticity after a stroke. Typically, if someone has a stroke or a bad head injury, they can actually get spasticity in an arm, and we can use botulinum toxin for that as well. So that's my day-to-day thing. I'm either doing Botox or prescribing medications or helping to manage some of the other complications that can occur with Parkinson's. So a lot of my day is spent trying to determine exactly what the patient is trying to communicate with me about what's going on with them, examining them from head to toe, making sure that they don't have any eye movement abnormalities or increased reflexes or abnormal walking that might make me think one thing. And then I'm trying to localize that, right? So I'm trying to go back to the spinal cord and the brain and trying to figure out, well, what level is this occurring at? Is it in the brain? Is it in the spinal cord, which can be neck all the way down to lumbar spine? Or is it even more peripheral than that? Is it in the nerves? Does this person have like neuropathy or some other, like a radiculopathy or something else involving their nerve there? And then I try to think of the actual pathologist causing it. So I've localized it, but now I need to think, is it something inflammatory? Does it sound like something vascular? Does it sound like something neurodegenerative? So something like Parkinson's, where the neurons are just dying for any particular reason. And so that's kind of that day-to-day thing. And then aside from that, working on that DBS program, which is more of that, my kind of like more administrative administrative duty. And then I'm not currently doing any clinical research, but my plan is that once we get this DBS program up and running, there will be opportunities to do some research in DBS, as well as work with some other clinical trials, probably in the toxin world and probably with some of the other newer drugs. Parkinson's disease drug development has sort of taken off in the last few years. There's even a newer drug that came out a couple years ago that doesn't work on dopamine like all the other drugs do. It actually works on an adenosine receptor, and so it's an antagonist to that. And so it actually helps with things like dyskinesias, which are those extra movements, or with wearing off, where patients fluctuate throughout the day in terms of being able to move and then not being able to move. So it's a great medication that we use there. So I guess at this point, I can just take any questions if there are any.
Questions, guys?
I actually had a question from Caleb at Shady Joe. What's the most rare pathology kind of diagnose?
Did you hear that?
I heard something about what is the most something about that I diagnose.
What's the
Can you
most
repeat it?
rare pathology you have had to diagnose?
I'm missing one word of that. What is the most what? Rare. Let's see. So one that's not, I guess it's not terribly rare. Well, I see it a lot more, but one rare thing. So there are what we call paraneoplastic processes. So these are diseases that are either autoimmune or they are related to cancer development. So occasionally patients, if they have a cancer, like especially lung cancer or a lot of the GYN cancers, their body can develop antibodies. We think that it's probably because their bodies are trying to fight off that cancer, but unfortunately it's not, it doesn't work very well. And so then those antibodies then will attack other parts of the body. Unfortunately, that can happen to the brain. And so we'll have people who develop like a autoimmune encephalitis. So I've seen patients who will ultimately look extremely psychotic. They can have almost like what we would think as like a psychotic breakdown. They can even have really bad seizures. They can have dystonia and all kinds of weird tremor. And then, you know, we run some labs and we'll find out that it may be due to that. I just recently, about a couple weeks ago, we diagnosed someone with another pretty rare autoimmune one called GAD65. So it calls something called stiff person syndrome. So this is one where they have frequent muscle spasms throughout their body, but if it gets really bad, they may not even be able to walk, and they can be really stiff and have really increased reflexes. It can also cause them to look a little bit psychotic, but they don't really end up really, they look more catatonic than having like hallucinations or anything. But we always want to make sure that we've identified whether or not there is a cancer there, because treatment of the cancer is ultimately treatment for that condition. I would say that's one of the, I mean, it's one of the more rare, sort of really interesting ones. Some of the attacks, spinocerebellar ataxias are also pretty interesting. I've diagnosed a couple of those. And there's one in particular, spinocerebellar ataxia 17, which can look very much like Huntington's disease. So you'll have a patient, they look like they have Huntington's, right? They're moving all over the place. They're having some cognitive difficulty, but we do their Huntington's genetic testing. They're negative for it. They may not have a strong of a family history for Huntington's. And so then you're just wondering like what's going on with them. And so we've had some patients that will go ahead and do the spinocerebellar ataxia panel. And we found that they have spinocerebellar ataxia 17. Which we do know looks very similar to Huntington's. So I'd say those are probably the two more rare ones. I don't think there's anything else interesting like from residency that I've seen. One of the most interesting ones, because you don't always expect it, and they don't always have the more typical cancer history. But the, you know, the autoimmune ones can cause anything. I've seen people with weird eye movements, like they'll have like eye fluttering, not the eyelid, but the eyeball itself will do like this fluttering movement, or will do like a upward turning that they can't control. So those interesting ones.
All right, questions, guys?
I had a question. You said that when you guys are putting the electrodes in, you guys can hear the neurons. So like, are you hearing them by like watching how the body responds, or like, is there a way you can actually like hear them with a machine?
Yeah, so there is, everything is hooked up to a machine, and we're actually like hearing the electrical activity of those neurons moving. And actually, in essential tremor, particularly, you'll hear it actually sounds like their tremor. They'll be almost like the same frequency of their tremor. So it's something that we're listening actually with our ear. And then the equipment is set up, like you can actually see some of the waveforms a little bit. So these are, it's always important to, like if someone, so we are concerned for like seizures in someone, we actually have to turn off their DBS stimulator because there's electrical interference that you can have there. So that there is an electrical like sound that you can actually hear.
Let's take one more. We have 2 minutes left.
I had a quick question. Did you apply to the PhD program, like, and did you get to pick your neurology PhD, or did you apply for a specific like MD PhD neurology program?
Okay, so there are two ways to do it. So, or probably it's just a third way too. But so I actually applied to medical school and got into medical school, and then decided, you know, hey, I really don't think I don't want to do research. So I then applied for the PhD at my same institution and got into that. But then once I was in it, was ultimately in the MD PhD program. And so I did all of the other requirements that you have to do for MD PhD. The other way is to just apply to the MD PhD program initially, And so you go into it, you're interviewing with MD PhD faculty, and then you're admitted to medical school as an MD PhD student who they know will be there for 2 years and then go on to their PhD and then finish out later. But I think myself and there was another person who did it the way that I did it, where they came in a little bit later. And then of course the third way would be, some people get a PhD like completely separate, either before or after medical school, and that would not be in any sort of specific program. They wouldn't have like the same NIH funding through the school that they would get for that.
Okay, well, I wish we didn't have to stop because I could listen to you for another 3 hours. So everyone, please thank Dr. Young, and thank you so much, Dr. Young, for coming in. Thank you so much.
Okay, thank you for having me.
Thank you.
Thank you.
Thank you.
Bye.
Bye.